we have a mixed panel of adult and pediatric gastroenterologists, pediatricians, and a surgeon. Our questions are going to be mixed, our cases are going to be only 2. But the idea is not just to stick to these 2 cases, but basically sort of have an approach-oriented plan whenever you see children coming to us with things like recurrent vomiting. Let's come to the very simple case first. 11-month-old child comes to the outpatient. History of vomiting, the mother complains, going on right since very early infancy. So Sandhya, what I would like you to do is just for the timing assume that you are a pediatrician and the mother has got this particular baby to you and she tells you this particular complaint. What is the next thing that goes on in your mind, or what are the questions that you generally like to ask to the mother when this thing comes to you?
What you want to find out is when the vomiting actually started. Was it within the first week of birth? Was it after they started solids? Whether it's just the milk that is being vomited, or you want to know the frequency. So you need a really detailed history, because one always knows that reflux is the most commonest disorder in this age group, but it's a diagnosis of exclusion, and you want to make sure you don't miss any serious illnesses that could be associated. And also particularly taken into account if there's a family history, because we know that's very common as well. Once one takes a detailed history, then you can decide whether or not the child needs investigation, and there are some salient features that are kind of key areas that you would want, which would make you think, yes, this child does need investigation, this is a bit more serious.
Yeah.
Okay. So in particular, if a child is vomiting and is gaining weight, looks quite healthy, it still could be gastroesophageal reflux, but it doesn't necessarily need any intervention, but more parental reassurance. However, if the child is losing weight, if their vomiting is not milk, if it's bilious, then that's suggesting perhaps an obstructive symptom or something more serious. If there's associated diarrhea, and at 11 months, forceful vomiting is unusual, but it's still something that's quite important to do. Also, reflux can cause respiratory symptoms, or respiratory symptoms can cause reflux. So you want to have a bit of an idea about cough, recurrent chest infections, perhaps they've been seeing the local doctor getting lots of antibiotics. And once you've got those details, then a detailed physical examination.
You said something about the family history. Why is the family history so important in the child with this sort of a history?
When you have recurrent vomiting and you have chronic vomiting, there are some disorders that are that do run in families, and there are some that are not. So it will help you in your thinking pathway as to whether this is a gastro-related illness or whether it's a metabolic type problem, and reflux itself. And motility disorders also run in families.
Okay. So, assuming that you have none of this so-called red flag signs and your mother says nothing of this is there, it's just vomiting, what would you do?
In my practice, if it's a healthy child that's growing, I reassure the family and I don't treat them. Right. If the parents accept that, I won't necessarily even do a basic investigation. Right. I will say it's a clinical diagnosis of reflux. If, however, there's extra anxiety, or there is a mild family history, or there's a bit of weight loss, not significant, then I would start thinking, do I need to confirm a diagnosis?
Okay. So, as she said, if none of these red flag signs are there and there is just vomiting, you don't require to do anything more. But unfortunately, our child, which you're talking about, of a reasonably good birth weight, but at the age of 11 months is just weighing 6.6 kilograms. The vomiting had started very, very early in life, almost since the first month of life, and is more or less the same as what it was before and is now. Mother gives history, this typically occurs after feeds. We asked questions about our red flag signs, but there was nothing else besides the failure to thrive. There was no diarrhea, no projectile, bilious vomiting, no organomegaly. Child's neurologically normal as far as could be judged in the outpatient. The mother did give the history that there were 2 episodes of hospitalization for lower respiratory tract infections. Child is right now primarily on animal milk with an intermittent complement. Baby now in mind, is there anything else besides this that you would want to ask in terms of the history before you want to think about what this child is really having?
You talk about this animal milk business. See, the vomiting may be a presentation of milk allergy, but most of the time you get other system involved, especially skin and respiratory. So if you have this combination of 2 systems involved, vomiting with respiratory like wheeze and skin problem, family history, whether any other features of metabolic condition like organomegaly, though we have not examined the child, and fasting causing vomiting or like that.
So this child, as compared to the previous child, do you think this child requires any investigation and treatment, or is this child going to get away with just reassurance and telling the mother come back after some time?
The significant failure to thrive.
Yeah.
That is a indication that this child is having vomiting, which is causing poor weight gain. So we need to look at it. If you have a child who is vomiting but doing well, his weight is appropriate, then just assurance and probably modifying the diet will help.
So this child you feel requires investigations, right?
Yep.
Yeah. Now, when you look at the list of investigations that are available to a pediatrician when this child comes to us, they are far and many. And I'm just going to show them here. What I want you to do is quickly tell us which of these or any other investigation that you would do in this particular child, and where, if at all, you would like to use any of these investigations in the management of a child presenting very similar.
First we have to make up our mind what we are dealing. You talk about gastroesophageal reflux disease, then all this investigation is valid. So we have not gone into the detail whether it is a metabolic or neurological
Correct.
cause of vomiting. For the discussion's sake, we are assuming this is GERD, and in GERD basically is a diagnosis, a clinical diagnosis. History and physical examination is enough. But that you have a battery of tests. None of them are 100% foolproof. Means there is no one test will tell you reflux is there or not. You have to decide the particular test depending on your clinical question. What is your question? What answer do you want? If you are talking about a child of respiratory symptom who doesn't have overt reflux, but you assume, you are thinking that it could be reflux-related bronchial asthma, there you have to choose PA study, okay, to document there is a reflux. Suppose if you have a child who is having esophagitis symptom, like he is having dysphagia, odynophagia, or is having anemia or iron deficiency anemia, so there you have to choose a bigger child with heartburn, endoscopy, to document esophagitis and take biopsy to rule out other causes of esophagitis. But where you are suspecting a child vomiting due to anatomical cause, like you are thinking it could be malrotation, it could be achalasia, there you have to do barium. Okay, so basically you have 3 tests, depending on the situation you ask. Barium cannot be the test to diagnose reflux, it's very poor. Regarding scintigraphy, actually this is not a good test at all. It is easily available and all pediatricians feel why not to get a scintigraphy which is non-invasive. But its accuracy is very poor. We don't have standardized norm to diagnose reflux, and it will tell you just postprandial, immediate postprandial reflux. It doesn't give you the late reflux. Scintigraphy is useful only one situation. If you happen to see a child with recurrent pneumonia and you are thinking it is a aspiration, microaspiration due to reflux, there you do scintigraphy and get a late scan after 24 hours. If there is a retention of the activity in the lung after 24 hours, that is the only situation where scintigraphy helps, otherwise not.
Right. Anything else? Any other investigations? What about, there's a lot of talk about manometry, motility studies. What about the esophageal monitoring, which came up a big way quite a few years back? What would you suggest?
No, manometry is not an investigation for reflux disease unless you are thinking that this child needs surgery and you need to rule out some motility disorder to decide what kind of surgery you want to offer. Otherwise, manometry is not required for routine reflux disease. Variation of PA studies have come. like Brevo capsule. Instead of putting that 24 hours tube, you put a capsule and fix it into the lower esophagus and do a 48 hours pH metry, or impedance study, which is come recently. We don't have much experience and not much of pediatric study to vouch for that impedance, but it's supposed to be superior to pH study because it will measure the non-acid reflux and differentiate between air and liquid also. To sum up, I will just put these three investigations. Barium, not to diagnose reflux, but when you suspect anatomical problem, stricture or malrotation. If you suspect esophagitis, child is having dysphagia or anemia, endoscopy and biopsy. And PA study, when you have extra esophageal manifestation, you want to document ES reflux before deciding treatment, their PA study.
So in this particular child we're talking about, assuming you have ruled out metabolic causes of failure to thrive and recurrent vomiting, which of these would you really do, or just the clinical history is good enough for you to say, okay, this looks like a
basically,
GER?
I will not do any investigation. He doesn't have features of esophagitis, he doesn't have true respiratory problem, only 2 LRTI may be normal in an infant. So I'll go by clinical features and give a trial of treatment. If he doesn't respond, then you investigate after 4 weeks.
Right. So you feel that treatment is necessary in this particular child. When you talk about treatment in this particular child, I can ask Dr. Fazal that, what are you really looking at? I mean, what are we trying to treat? Are we trying to reduce the vomiting? Are we trying to take care of the growth? So what are in general, just briefly, are the principles of management in this particular child?
Now this growth is compromised secondary to his reflex and complication, GERD. Try to control the primary problem, then expect growth to come back normal. Treatment doesn't mean that always drugs. By the second case, it's a GERD. He has a gastroesophageal reflux disease, 2 respiratory symptoms, twice he has LRTI, and plus he has a growth failure. As I agree, initially before we rush for all investigations, parents may not agree in our clinical practice, trying with simple drugs, and before drugs giving a advice, small frequent feeds, propped up position, avoiding liquid feed, and then next step is to go for a drugs.
Good. So you are saying the non-pharmacological treatment must
Yes.
precede the pharmacological
Right.
treatment. But let's look into what we talk about a non-pharmacological treatment. And Ujjal, can you tell us the scientific basis, Ujjal? Yeah. Can you really tell us, is there enough evidence for us to recommend this? Or is it something that we have been doing all the time? We think it's an impression that it helps us in terms of treating reflux.
Okay, but talking about science behind non-pharmacological therapy, there is not much. Position in infant, it has been shown, prone position definitely decreases reflux, but there is a risk of SIDS, sudden infant death syndrome. So in infant, it is a tricky issue. You keep the child who is having reflux in prone, but he can die of SIDS. So it's not recommended because the risk is high. Older children, left lateral position is shown to decrease reflux. Okay, there is a science behind it. Other than this, there is any objective evidence to say that lifestyle modification or anything helps. We do advise bigger child that small frequent meal, and if it is obese, weight loss, avoid caffeine, alcohol, tobacco. Okay, these are all part of management. And you want me to talk about thickenings? Free thickening.
Has thickening fluids really shown to reduce reflux?
It doesn't. It has got cosmetic value. If you thicken the feed to an infant or to a small kid, mother will feel happy because the number of vomiting will decrease. But if you do the PA study, PA studies have shown there is no change in reflux index. So in true sense, it doesn't help. It gives a cosmetic effect, food thickening.
Right. The standard recommendations which you talked about are 2, which I want you to consider a little more in detail. Most of the recommendations for management of GER come from West. One of which is the thing about cow's milk protein allergy. What they would suggest is cow's milk protein allergy may have a role in reflux, so they would advise maybe putting the child on a hydrolyzed formula. what is the relevance of that recommendation in India today, firstly, and also second, the SIDS that you talked about, again, is a recommendation from the West. What is the relevance of that in the Indian setting?
I will be able to answer your first question. Second question, I am not the competent person to answer. Milk allergy, yes, it is a problem in India also. We have documented mainly GI problem with milk allergy. If you talk about a baby who has come to you at 1 month and vomiting, straight away you ask, okay, empirically you stop milk and switch over the hydrolyzed formula. What is the hydrolyzed formula in the market? We don't have a single hydrolyzed formula or amino acid based formula in the market. So we have to rely upon soy. Then there is a big problem of soy. So and I don't think it is right that we stop milk and so we say that it's a cow's milk allergy and you stop. In Indian context, is a tricky issue. We don't do it.
So you would not recommend stopping milk in the present setting?
Yeah. Seeds part, I don't know how often we encounter. In my experience, probably it is not a problem. So nursing in prone position might be of use. So if you want anybody's help to clarify this issue.
Would anyone in the panel want to comment about the SIDS? Because we keep hearing this about SIDS, baby should, well, if at all you look at science, it has definitely shown that in the prone position, you have less amount. There is no doubt regarding that. The issue now is, do we accept these recommendations? What would you tell the parents over here that, okay, you still need to do that, put this child in a particular position, or do we say, we don't have so much of SIDS in India and we still put the child where we have science to say that's least reflex? Would any of the panel like to comment on this particular? There are no Indian guidelines for this. Yeah, sure.
Actually, at JJ Hospital, we had a long-term ongoing study on children presenting with infants and children presenting with GERD, and we routinely used to put them in head high and prone position, and at least I don't offhand remember the figure, but it's something like 260 patients that we studied. We did not encounter a single SIDS because of the positional problem. Whether this is statistically valid or not is another point. But that was my observation.
I'm sure in the discussion, if there are any neonatologists or other ones, we could take that. But that's something that's always our concern, because if you have scientific evidence to show that reflux is less in the prone position, are we right in just taking the recommendations from the West and using it in our situation? Okay.
Basically, I think the gastric emptying is much better in prone position, and that's why the incidence of reflux is less.
True, correct. When we decide on starting the pharmacological treatment, what are the criteria that we use? We have used a non-pharmacological treatment, we have given it a try. When do you say that two things, my non-pharmacological treatment is not working, I need to go on to medical? Or when do you say, I don't have time for my non-pharmacological treatment, child has got very severe GR, I need to immediately start medications? Sandhya, could you tell us?
If you've started the non-pharmacological and you're reviewing them and the child continued to lose weight, it's not working, one would consider treatment. If the child, however, has signs of esophagitis, be it coffee ground vomiting, then I would start treatment immediately. I wouldn't bother with the lifestyle changes or the position changes. The main issue I feel with regards to reflux is the effect of the acid on the esophageal mucosa. And so therefore one really needs a protective role, and that's where the H2 blockers or the PPIs come into play. As far as prokinetics, the issue is to try and get the stomach to empty better and to use drugs that are prokinetic, but they're all rubbish. The only one that was decent was cisapride. Now in the Western, in the UK and the USA, cisapride is not available at all. The reason being is because there have been deaths associated with it. These were adults in the US and they had undiagnosed cardiac anomalies, usually Wolff-Parkinson-White, but some others as well. For a short time, we were able to do baseline ECGs and still prescribe cisapride. And cisapride did improve reflux. We have studies showing, pH studies before and after trials of cisapride. Now that is no longer available. There are the other motility drugs are for want of a trial. My personal practice is to say we will try this for 4 to 6 weeks. If it doesn't work, we will stop it. I will not continue it. Domperidone is the cheapest at the moment, and that's our first line. There is a study, however, coming out hopefully in the near future of domperidone in the under 1-year-olds to know truly or not does it help with reflux. Metoclopramide is a drug I'm not particularly fond of because of the side effects. In fact, the only time I use it is for occasional placement of nasojejunal tubes. So for reflux, I don't use metoclopramide at all. As far as erythromycin goes, the reason at a low dose of 3 mg per kilo, it works on your motilin receptors, and so therefore there is theory that it can help with your gastric emptying. If a child has not responded to domperidone but has got significant symptoms, still losing weight, very irritable, I would consider again a trial of erythromycin. In the younger ones, it's not an issue. The problem is it needs to be given 4 times a day. But in the older ones, the nausea associated with it and is often a non-tolerance problem with erythromycin. And also in my practice, trying to explain to the GPs that it's not the antibiotic dose, it's a low dose, is a continuing challenge.
Sure. Just sticking to the prokinetics, Ujjwal, we have cisapride available with us. So in our Indian situation, would you recommend any of these drugs, and when would you recommend?
Ashish, I want to make one point clear. Before starting treatment and what treatment, we have to decide what is the diagnosis. If you feel this is a reflux, not disease,
yes.
Child is just regurgitating, other is maintaining weight, there the no question of drug, you go for whatever you feel like, food thickener, blah blah blah, whatever. But this lifestyle modification, food thickener, small frequent feed, does not help in disease.
Correct.
If you deal with a baby who is having reflux disease, you go for drug. And out of all, only drug which is shown to be a much better than any other drug is PPI. Okay, prokinetic role is big query. Except the situation where you are suspecting probably there is a problem in gastric emptying. There prokinetic helps. But in the routine day-to-day practice, managing GERD, adding prokinetic to any of this H2 receptor blocker or PPI, it doesn't help.
So what you're saying is you would not use a prokinetic drugs in a management of a child like this,
so
who
basically
has only GERD.
Yeah, but see the problem in pediatric practice is that we treat vomiting, what you started with. Vomiting is a different entity, reflux disease is a different entity. What we are telling vomiting, it is not true sense vomiting, it is a regurgitation. There is no role of this prokinetic drug.
Right. So you would not use
except if there is a delayed gastric emptying. So basically you have to hit the main thing is that acid. What Sandhya said, you need to suppress the acid, and for that there is no comparison of PPI with any other drug.
Fine. So either Sandhya or Ujjwal, one of you can take. Sandhya, would you like to talk a little bit more about the acid suppression in terms of, let us give the background what's available in India. We have omeprazole, we have lansoprazole, we have pantoprazole, and their derivatives.
The problem with the PPIs is the limited number of pediatric studies, particularly in the younger infant. Traditionally what's been out longer is omeprazole. There is some data recently for sort of 1 to 10-year-olds. As far as the lansoprazole, all the data is actually being extrapolated from adult studies. The advantage is lansoprazole, there is the FazTab available, which can dissolve under the tongue. Omeprazole comes as capsules and as something called MUPS, but although it's supposed to be dissolvable, it actually isn't very dissolvable. In the UK, omeprazole is by far the PPI that is prescribed the most. However, there is a study coming out again called for young infants for PPIs, a new one called rabiprazole. That's actually going to be a multi-centered international study, and hopefully will actually provide a PPI that is suitable for the young infants. There is, in my mind, no doubt that the PPIs are superior to ranitidine or cimetidine as H2 blockers for acid suppression. However, they do work on different receptors and pathways, And in those who have very severe reflux, who have, say, profound hematemesis, melena, or ulceration, there is also a vogue to actually start with a PPI and add in an H2 blocker second, but PPIs first.
Right. My concern is the recent data which is showing the PPIs are not really useful in young infants less than 1 year, especially lansoprazole, which we used to think would be of choice. So what we are boiling down to the fact is none of the prokinetics seem to be working. We thought PPIs would be working. Now we're finding some evidence to suggest PPIs don't work less than 1 year of age. So we really have very little pharmacological therapy to be used in young infants with GER. Is that, would you agree with me with that?
Absolutely.
Right. Next is surgery, and this obviously question goes to the pediatric surgeons. The role of surgery in GERD has had its ups and downs. There was some time where it was used as a last resort. Then came a phase where it was used slightly earlier, especially in special situations. What is its role as things stand today? When and where should surgery be used or be thought about in a child, specifically with GERD?
Let's first think about the non-controversial indications for surgery, and for which barium study is absolutely mandatory, because that will show us all the anatomical aberrations that are there. For example, if there's a hiatus hernia, no amount of pharmacological therapy is going to correct that. So that's a definite indication. So also if there's a stricture of the esophagus, or sometimes if with intense esophagitis, the lower esophageal sphincter may go into spasm, which appears like a stricture. Either ways, this is a definite indication for surgery. If a child is presenting with heartburn and symptoms of esophagitis, and if the esophagoscopy shows gross ulcerations, which is evidently going to go into a stricture, that of course would definitely need surgery. Also, if there's associated malrotation, which has been found in certain large series which was studied in UK, there's a definite indication for surgery, because there's a malrotation needs to be corrected. I have seen some cases in infants where the clinical diagnosis was certainly a GER. However, it turned out to be pyloric stenosis. And so, a barium study cannot be underestimated. And I feel as a surgeon, it is definitely the first investigation to be done before you start on any kind of pharmacological or lifestyle change treatment, to know whether we are dealing with any kind of anatomical problem which needs surgical correction. Of course, the other relative indications would be failure to conservative treatment, failure to respond to conservative treatment. Near-miss SIDS again is a controversial thing, which used to be a definite indication some time back, is now again under study. Because now the recent reports are showing that when near-miss SIDS was blamed on reflux, it is not so.
Right.
The other thing which I would definitely like to mention is asthma.
Okay.
Whether the chicken and egg problem comes in, but when you're suspecting microaspirations, it has definitely been shown that the drug requirement for treating asthma definitely is reduced after doing fundoplication.
Okay. So what you're saying is surgery is primarily used in secondary causes of GERD, where there is an underlying cause which basically causes the GERD. There you would like to do surgery. And of course, as you said, you would not do surgery till you have to diagnose the underlying cause of that particular thing. The second thing which you said about where there was a lot of esophagitis and ulcerations, you would like to go surgery. Is it feasible to think that you would like to give a medical trial?
Yes,
before you go in for
certainly.
surgery?
Certainly, one should give a proper medical run of treatment, and if compliance is doubtful, then I would even admit the child under our circumstances, and under supervision give a thorough proper treatment trial. And only if the child fails to respond, do a repeat scopy, find out what's the situation. And in all these cases, I would again underline that biopsy is a must. If you're doing endoscopy, seeing that much of ulceration, Barrett's esophagus, which was not thought of to be very common in children, is now found to be having quite a significant incidence. So,
right. When you say, any of the panel, when you say give a failure of medical therapy or an appropriate time, is there a fixed time? 6 weeks, 2 months, 3 months of all the measures that we talked about? What would a pediatrician, how long should he give?
You see that GERD, if you are sure it is especially esophagitis is there, erosive esophagitis, minimum time is 3 months. So, and then you can give a trial of withdrawal and see. So, at least 3 months trial is required before telling is not responding to anything.
So you are saying 3 months conservative and medical plan treatment before going in and planning surgery, right? Ibrahim, we have been talking about GER and GERD in the smaller children because that's what we commonly see, the pediatricians see. But with present lifestyle, with obesity and all its issues, I mean even older children and young adolescents are going to get things related to GER. How common do you see it in your practice? Do you treat it in a similar way? Are there different guidelines for treating GERD in older children as compared to what we have talked about?
Maybe I have to address only the few people in the audience who deal with people who can walk on their own, talk on their own, because we deal with adult patients and we would consider it bad manners if we spoke to the mother of our patient.
Right.
So we get our history more clearly. So my take on GERD in adolescents and in adults is slightly different from what has been said. I largely agree with what has been said, but if I could just reiterate a few points that have been made. We don't consider vomiting as a manifestation of GER. For us, it is heartburn and regurg, about 70% sensitivity for each of these, and 90 to 95% sensitivity if you put them together. So in that respect, I agree with Dr. Podar that a person who presents with only vomiting, we wouldn't think of GER as the first indication, as the first disease. But presuming we're talking only about GER, I'm just going back through some of the points that have been made. We don't investigate all of them. The investigations that we focus on mainly are endoscopy, because it's also good for us, not just for the patients. But the purpose of doing an endoscopy is to stage the disease, not to make a diagnosis, because more often than not, we get non-erosive reflux disease than erosive reflux disease. So we don't do an endoscopy to make a diagnosis. We do a pH metry only when the child or the person has unusual manifestations. In adults, that would mean either extraesophageal symptoms or non-cardiac chest pain, where the diagnosis is not clear and you want to document that this is indeed reflux. The other situation we do it is in a patient who's been given optimum treatment, you're strongly suspecting reflux, but the person doesn't respond, and you want to know if your treatment is adequate or whether we have to look at another cause.
Right.
Coming to treatment measures, there is, like Dr. Podar mentioned, not much evidence in favor of all the lifestyle changes. And there's unlikely to be ever a randomized controlled trial on any of these, but they're all common sense measures that we would recommend for our patients. We would never stop at just the lifestyle and diet measures. We would put them all on medications, and in our case, that would mean a PPI first and a prokinetic for those who have what we call volume reflux, predominant regurgitation, accompanying bloat, and just contents coming up into the mouth with water brush. There we use a prokinetic. I agree with Ujjal that the data say that prokinetics are not as effective as a PPI for reflux disease, but there are certain situations where we use it. And finally, when it comes to surgery, there's a slight difference in the thought on this. We don't reserve surgery for patients who do not respond to medical treatment. In fact, we consider the ones who respond as more likely candidates for surgery. So the ones we reserve surgery for are the ones who need either a high dose or who need to be on lifetime medications and are not keen on doing it, or who have associated anatomic disturbances like large hiatus hernia. As far as ulcerations and strictures go, as adult gastroenterologists, we would rather treat them endoscopically before sending them for surgery. So in practical terms, there's hardly 1 or 2 patients per year that we would send for surgery. All the others would be medically managed.
So there does seem to be some sort of difference in how we approach it in the smaller as well as compared in the older child. Okay, we have spent a lot of time and we have very little time left. So I'm going to ask the panelists to be a little quick about discussing this case. We'd go